Thank you, Alphonse. It's a big honor to be here. It's an honor also to be the first speaker and introduce the issue on his bundle pacing. So briefly, I will treat some different point in literature, recent literature in his bundle pacing. So why we have to do it? What is pace-induced cardiomyopathy? This is a new entity described recently and means that we have a depression in ejection fraction, approximately 5-10 points. And this is a very nice paper in which you can see that some characteristic of univariate, but at the end the multivariate is something that we already know, and that are baseline left bundle branch block, the pace QRS duration, and ventricular pacing frequency is what we know from our experience and what we expected. And if you analyze every single of these three patterns, there is a difference. But what is more important that is if you sum all these kind of parameters, so three predictors, you have 100% of pace-induced cardiomyopathy. And already we, with the Pugal group, we put together approximately 80 patients with pace-induced cardiomyopathy. So the previous history of pacemaker was approximately 5 years, and we have a percentage in this kind of patient of 100% almost. Mainly there was a complete AV block, 75%, and this is a clear example, RV pacing at implant at 6 months, and this is an example in which after years you can also find a HIS. That means that the progression of the disease, of the conduction disease, is not so we expected, but is still we can pace the HIS. And in fact, in this group of patients, if you see, of course, you will expect a shortening of QRS duration, but it's not so clear that we have an increase in ejection fraction, a decrease in functional class. But what on feasibility? We describe with this group of friends what is going on in the literature in about 1,500 patients. And as you can see, as already Alphonse mentioned, there is a difference from the first study in which there was a stylet or the handmade stylet curve compared to all these studies, all are made with 3830, and you can see that the feasibility, so the success rate is approximately between 80 and 90, in some cases more. Those are as expected, the threshold, and which is higher compared to the standard pacemaker, but we discuss later on this. Also, this is another interesting paper by a single center. The story of this single center is high experience in AP, is a US center, and they started to do his pacing, and then they describe how is the learning curve. So it's something that may be interesting for all of you. And what is nice to see is that is easier in patients with narrow QRS, like in this case, and is more difficult in patients with conduction disturbance. And of course, there is over time an increase in success rate due to a better learning curve. This is just an accepted publication for our group in which we add another thing. His bundle pacing is mainly is not an interventional, and that is the key of the procedure. Is an electrophysiological procedure, so you don't have to look at fluoroscopy. You just have to look AP signals. And here is a trace in which you don't need to see the fluoro. As you can see, this is the electrograms and this is the endo. So you can see AAA, and when you move forward, you can see then H, then you screw, and this is a perfect spacing. So it depends on, of course, not all patients are so easy, but it's something that you can do. You can abandon, really, what is the fluoro, just look and AP. And this is another example. Again, big A, then you move to H, and then. And this is, we already did approximately 80, 900. Now we are doing all with the no fluoro. But in this series that we describe, as you can see, in the 80% of cases, we just do not use any fluoro for his. Of course, then you have to cut, to see the slack, to put the atrial lead, you have to put some fluoro, but only in few patients. And in any case, in only those few patients, you have just to do just a small of fluoro, because you have to look at signals. What about long-term follow-up? There are 3 papers I want to show you. The first one is a collaboration with the group of Pugal. We put together our long-term experience, so more than 10 years. And at the end, we had approximately 900 patients. It's worth to know that the AV block is quite consistent, 42%, sinus disease, and so on. That's the clinical condition, and this is the pacing threshold. As you can see, the implant is like in the previous meta-analysis I showed you, is 1.6, and there is a little bit increase in threshold at follow-up. What about capture threshold, the problem of the lead? So we have some problem. We have a capture threshold more than 2.5 in 27% of patients. And interruption of his pacing is worth to know that this one is 7.6%. And if you consider that a recent meta-analysis more than 1,000 patients is approximately the same. And it's also worth to know that in RV pacing, the dislodgement rate is not 0. Is accordingly to different reports, is between 2 and 6%. And we also compare, because the history of the his pacing has been cut at approximately in 2010, 2011, with this new fixed lead. And this lead, this delivery, seemed to change the history. So if you see here, this one is with the deflectable, but we know with no septal curve. So we are waiting for this new 304 with septal curve, and this one is the fix. So as you can see that there is a dramatic change in dislodgement and in threshold. So it's much better with the fixed curve compared to the first one. And look, what happened after 14 years? We replaced this pacemaker 3 days ago, and still we have a nice his signal, and this is non-selective, and we still have a nice selective with good threshold after 14 years. This is the experience of our host from London. So a British group, they have more than 500 patients, and the success rate with different groups is between 80 and 90%. There is also in what they describe a learning curve in terms of less fluoroscopy, but still high. There is also in his capture, and those are data from the different indication, which are almost the same indication that's the previous group. So normal ejection fraction, some patient with impaired. The proportion of patients with this conduction disturbance is so approximately 200 is 40%. The patient indication is AV block in almost half of the patient. And again, they observe 7.5 is patient lead require intervention, which is more or less our experience. But again, 7% of lead revision was seen in 15,000 of patients with indication for BIV, and also RV still is between 2 and 6% of patients. What about effect on function, LV function? So again, if we look in our meta-analysis, we observe that this is not in all the world population of more than 1,000, but is approximately 300 patients. And what is nice to see is that there is a sort of rule that we also have. This is our experience of my center. So patients with preserved ejection fraction still maintain the normal ejection fraction. Patients with depressed ejection fraction have an increase in ejection fraction during follow-up. And this is also from our experience. We divide in more than 45 and less than 35, and we have a nice increase in our experience in all the different class of low ejection fraction, I mean very depressed, moderate, and mild. What about effect on hard endpoint, which is heart failure, hospitalization, and survival? This is really a milestone of a trial. I have no other word than show you this picture. I think it's fundamental in the history of this bundle. Is the paper from our friend Pugal, and show clearly that in a very large number of patients, more than 400 each group, one with his spacing, the other one with RV. And this RV is not only apical, half of the RV are on septal position, and they look at very hard endpoint, what we see hard endpoint, so which is death, heart failure, hospitalization, or upgrading to BIV, and with the mild follow-up, I would say, not so prolonged, they observe a significant difference in this hard endpoint. And what is also nice to note is what I said you before. The incidence of PACE-induced cardiomyopathy depends on three factors: left bundle, how large is the QRS, and the percentage of pacing. Again, of course, if the patient is paced just a few seconds per night, you will expect to have a depression due to the apical pacing. So patients who need high percentage of pacing will benefit from his bundle pacing. What about indication for AV block? Again, there is this paper from Pugal group. They observe that in 100 patients, if you divide in nodal or infranodal, they have a different behavior. So there is majority in the infranodal of non-selective compared in patient with nodal, in which you have half and half selective and half non-selective. I will discuss later if there is any difference, or we'll discuss later on in the meeting on the different aspects of selective and non-selective. And what about selective or non-selective? Again, a paper from US group. They compare in a very large number of patients. This is the endpoint, but this is the primary endpoint. So primary endpoint, again, death or heart failure hospitalization. There is no statistical significance between those two treatment, and this if you analyze in red selective, in blue non-selective, heart failure or all cause, there is no difference in terms of these secondary endpoints. And finally, guidelines. For the first time, his pacing has the dignity to be mentioned in guidelines. And if you see patient with AV block who have indication for permanent pacemaker, left ejection fraction between this gray zone, 36 and 50, are required to have a ventricular more than 40% to maintain physiological. At the same time, they put CRT or his bundle pacing. Also, this is for patients with the mild depressed ejection fraction. For the other, in other case, they put 2B. Thank you for your attention.